But yeah, I think we'll go ahead and get started. And so we've got two speakers today. Our first one is on the topic of measles false positives. Allison Kaiser Matobo, I believe, is with us.
Yep, I'm here on.
Okay, do you want me to share? I have a PDF of your presentation.
Yes, let me share my, oops. Can you unshare the agenda and then I'll share slides here. All right. So Tennessee did an interesting presentation on one of our vaccine preventable disease calls about measles, PCR syndromic testing, and false positives that they've gotten. So I just kind of wanted to go through these slides, Tennessee slides, with you guys. So Tennessee had a clinician that reported a 6-year-old had tested positive for measles, but this child did not have any risk factors for measles infection. Travel, exposure to a person with measles, no measles cases in the state. However, this is PCR positive, and so we have to treat it like a case until otherwise proven that it's not. And her clinical presentation was not classic for measles. So she had fever, cough, maculopapular rash, but did not have some of these other typical symptoms of measles. And the provider of this child had ordered a syndromic PCR test to identify what might be making this child ill. And it was a panel test. And these are the targets on the panel. And that panel included measles. And so this particular child tested positive for enterovirus and measles virus. And in the comments of this PCR panel, it says patients who have received a recent measles live virus vaccine, MMR or measles, within the past 14 days could test positive due to the vaccine and may not have a true measles infection. So again, this child did not have any typical exposures, but they decided to keep the family home until they could get vaccine records to see when this kiddo was, to see if the vaccine might have made this PCR test come back positive. And they did send the specimen off to CDC, and it did come back consistent with the vaccine strain. So this kid obviously did not have measles. And they had another case of a 1-year-old, kind of same situation, 1-year-old previously vaccinated who tested positive for measles. The clinical presentation didn't exactly match measles, and the kid had no risk factors, but did have recent vaccination. And again, these are the targets on this particular PCR panel that these providers were ordering. And Tennessee did talk to the providers that were ordering this panel, and many of them had no idea that measles was part of this panel, and they were not thinking that these patients had measles. And so, they were not necessarily purposefully wanting these kids to be tested for measles. And so, because of these kind of false positive tests that they were seeing, they wanted to know, how often is this PCR panel being ordered, and how often are they positive, and who tests positive. Oh, and I did not clarify, this PCR panel is being done by a national commercial lab. And so all these tests are being ordered through one lab. And so they talked to states to see, they talked to this lab that's doing this panel to see who had been ordering this test. And Nebraska is one of them. So at the time of this presentation, 1,500 tests were ordered in 25 states. Nebraska has not had a positive, even though providers in Nebraska have been ordering this panel test, we have not had a positive come back on this test. And then 17 were positive. Out of that, 1,500, 17 were positive for measles, and the majority were found in Tennessee. And so that's kind of why Tennessee kind of alerted everybody about this problem, because they had seen the majority of these measles tests coming back positive on this PCR panel. And most of the people who tested positive were like infants, young kids. And a lot of the kids that came back positive for measles also came back positive for other things, other targets on this panel test. And so again, none of these patients, so this syndromic PCR test was incidentally detecting measles virus, because again, none of these kids had a measles consistent clinical presentation or known risk factors, but they had all had recent vaccination, which explained their positive PCR. And measles vaccine virus D and RNA can be detected 100 days after vaccination, which is quite a while. And 1 in 20 people develop a rash after receiving a measles vaccine. So some of these kids who tested positive for measles did have some sort of rash that was a result of the vaccination and not measles. And let's see. So this is basically just saying, really evaluate if somebody needs to be tested. And if they do, that testing should be guided by differential diagnosis. And again, these providers a lot of them did not know that measles was part of this panel. And so they were not necessarily wanting their patients to be tested for measles, and they were not thinking that these kids were an actual measles case. And then of course, if measles is suspected, call your local health department, your state health department immediately, even before we get test results back. And then this is just kind of the incubation period and infectious period for measles. So you're infectious 4 days before and after rash onset. And this is kind of what public health, we take measles extremely seriously because measles is incredibly contagious. And so typically we do contact tracing, we verify immunity, post-exposure prophylaxis if indicated, and of course we do isolation and quarantine. And so this is just kind of for public health when we do get a positive measles test, like on one of these PCR panels. We want to know if the measles vaccine was received. Are they epi-linked to a measles case? What's their travel history? What is their clinical presentation? If they're not recently vaccinated, this is we consider it a confirmed measles case and act accordingly. And then if they're vaccinated in the prior 21 days, no epidemiologic risk factors and an inconsistent clinical presentation, this is not a measles case, and no further public health response. And remember, the comments on the lab test said vaccinated within the last 14 days. So they're asking public health to really look at the last 21 days instead of the last 14. And if they are recently vaccinated and they have a risk factor, then this could be a true measles case, and you really need to act as if, it's a real measles case until you have, and in that case, we would send specimens off to CDC and we would act like it's a measles case until the results from CDC come back to say that it's a vaccine derived measles. And so this is kind of their point. What's the role of measles testing by syndromic PCR panels? What is the likelihood of detecting an otherwise unsuspected measles case? What's the harm in telling a vaccinated individual that they might have measles? And how much public health work is created by incidental measles detection? Because measles can suck up a lot of resources and a lot of time and money, to follow up on, a positive measles PCR. And I think that's it. Yep. So I will stop sharing so you can put the agenda back up. This is, I saw the question from William Bolte. This is a respiratory swab that they were doing on these kids.
Great. Thanks a lot, Allison.
Yep.
Very interesting. Moving on, next, we're going to have Ishrat from DHHS talk about a recent lab survey that some of you might have seen regarding Candida auris surveillance in Nebraska. So Ishrat, if you're with us.
Yes, I am. Can you hear me?
Yes, I will stop
Okay.
sharing, see if you can bring up your screen.
Okay, let's see if I can do that. All right. Can you see my screen?
Yep.
I'll do
Got it.
the slideshow. Okay. All right. So this is a qualitative analysis of Candida auris laboratory surveillance in Nebraska. So my name is Ishrat Kamal Ahmed. I'm an HAI-AR epidemiologist with the state. And I want to start thanking all of you who have actually completed this lab survey. And Lisa Young from College of Public Health, she was a student. She also helped me with this analysis and the survey. The reason I just want to quickly say why we did this survey, because we were having a lot of questions from others asking, you know, are we seeing any Candida auris in the state? What are we doing? Are we not identifying it, but it's there? So we kind of wanted to know what's our capacity in the state and what are the gaps and what can we do to make it better, or what we're already doing right. So this presentation today, I'll try to be very quick. There's some background and rationale. Some project aims. We had two aims. Aim 1, which is a laboratory survey, and there was a aim 2, and I'll talk about it a little bit later, and some recommendations. We're going to have some questions and answers, but I want to let you know that when it comes to very technical lab questions, I'll probably refer to Dr. Ivan, Ben, or some of the other lab leaderships here. So the background is that, you know, history and prevalence, as you all know, of Candida auris, you know, started first discovered in 2009, and in the United States, it was found in 2015 in Illinois and New York. I'm just going to go over it very quickly, just to show you how it spread. You know, it was spreading all over, and now in 2022, we are seeing way more cases, you know, in all over the states. And if you look at Nebraska, there are other states in Iowa, Colorado, where they already have some Candida auris. So in Nebraska, so far we had 2 Candida auris, but those 2 were not. Those 2 were imported Candida auris. They came from another states. So we haven't identified any so far, which is a good news, and we want to keep it that way. Why Candida auris is an urgent health threat? There are 3 reasons. One is that it spreads very easily and it's really hard to get rid of. The mortality rate is very high, and it has a phenotype that's very, very multi-drug resistant. So some of the pitfalls, one of the biggest issues with Candida auris is that laboratory misidentification. That's been an issue with any Candida auris in any other states. Some of the things that are really of concerns is that some of the laboratories do not speciate all Candida growth in the culture. Many clinics do not actively screen patients for Candida isolation. And although, you know, it's a nationally reportable disease, it's only reportable in 23 states. And in Nebraska right now, it is not reportable. So we can't really, you know, have a very good surveillance when a condition or an organism is not reportable. And then many commercial automated ID systems will misidentify CRAs. As you can see on the left side, you know, how the species are pretty close, you know, in the tree there. And on the right side on the table, you can see how some of the systems that's been used to ID Candida auris can be misidentified. For example, Vitic 2, you can see that most of the Candida auris would get misidentified as Hemaluni. So there is our even bigger list. I just, I'm showing you the shortened version, and I'm sure you, some of you are aware of it too as well. So in this project, there were two things that we looked at. First, what we did was we had a survey, and I'll show you what the questions were, and we sent it out to all the labs here, and some of you are present here, so you are familiar with that survey. And so we're gonna share the result of what we had seen. And the second thing is that Nebraska Public Health Lab, NPHL, receive reports on all the Candida that get cultured, a monthly basis at, Nebraska Medicine. And so there are like 32, 34 monthly cultures that come in. So we kind of looked at where these cultures were coming from, who are these people, what are we seeing in Nebraska? So does it cover, can it be applied? What our findings, can it be applied to the whole population of Nebraska? Are we getting only from Douglas, Lancaster area, or are we getting the cultures from other areas as well? So first I'm going to talk about the laboratory survey. So there were 39 laboratories that actually sent culture to our system at the state surveillance. And some of the sentinel laboratories, they have their own capacity for microbiology testing in-house. Not all of them have it. Data collection, we had 46 questions in the survey that we built in RedCap. Some of them were multiple choice, some of them were short free text. And the questions that we asked were regarding lab ID equipment and resources, details on ID procedure for potential Candida auris, any barriers, any guidance, antifungal susceptibility testing, colonization testing, and state reporting. We did not include all of the things in this report because some of the questions were incomplete. So this is the result. If you look at this map, there are 30 laboratories from all over the Nebraska who sent the response, and we had a 76.9% response. So thank you for that. This is really great to get a clear picture. It was from 23 locations in Nebraska. Many employees were staffed, 22 employee lab, or 40, median was 14. There were some questions about this. I think some of the labs might have included additional staffing from other areas. So this number may not be the true representation. So one question was, what are the laboratories using for their ID process? On the left side of the table, you can see that out of all the respondents, we see that the highest number was multiplex PCR. That's been getting used, and the second highest was MALDI-TOF. And then there were some other ones too, but we didn't, really get to that granular level. And on the right side, you will see this circle of the pie chart. I don't have the percentage here, but the visual is pretty clear that most labs do have the fungal culture processing capacity in their system, in their lab. And then on the table below, the horizontal bars, you can see that we ask questions in what types of scenarios the Candida is speciated. And so this is a question where labs could choose more than one answer. And it looks like most of the time it's done when the provider is requesting that the species should be, the Candida should be speciated. And then there are a few labs that, 5 to 6 labs that always speciate Candida. Some only do it if it's from a sterile site. For the next slide, we asked, describe the process in which your laboratory would pursue CRS identification if they were to do it. And it looks like there were two main themes identified that, everybody, almost 22, wanted to identify Candida auris, which is a very good thing too, that because we want to know where it's, what's in our state. And some of them said that they didn't have the capacity, so they would defer it to the other laboratory. But of those that would do this culture identification, they are going to use MALDI-TOF. And that's because most likely because they're already using MALDI-TOF. Then we asked about any kind of barriers that they can see when they're trying to do especially for Candida auris, not for Candida, but especially for Candida auris. What are some things that they see as barrier, and what are some things they want to see happen? So on the left side, you'll see the pie chart. Most of them said that they do not have any guidance. And this guidance includes internally, like inside the lab, and also from outside the lab. And survey response to barriers were all over, but most of them actually said that they had no barriers. But those that they said that they had some barriers, lack of training is one in identifying Candida auris that stood out. And there were some other ones, like poor communications, lack of guidance again, lack of material resources, and financial barriers, of course, which we kind of are aware of right now. And then the next one, then we asked for a specific type of barriers. If we want to do a guidance or support, how can we support the labs? And so these are some of the things that labs are thinking. Laboratory CRS identification, they want to do it. That's the highest number, the very bottom bar you can see. And then the second one was that screening for colonization, which is probably not a lab decision, which is a clinical decision, and then or a public health decision. And also there were some that stood out, the sample collection procedure, they're not that aware of how to do it. And then they also want to have more information on how to ship it to any other reference lab or state public health lab. And then some wanted infection prevention guidance, and some wanted to have more information on MALDI-TOF validation. So basically the survey summary is this, that, there's a misidentification potential there. There is some specific things that they listed that came up, MALDI-TOF is essential. And then there is potential for undetected CRS, which is, not having screening, using only multiplex PCR, and only using some specific fungal selective media. And then the very thing that stood out was guidance and education. There was a desire by the laboratory personnel to have more guidance within the laboratories and from the outside sources. And for the second aim, that was all the data that was coming into NPHL. We just looked at the 2022 data because there are so many of them. And we looked at, what type of species coming in, HID groups and everything, and outcome was what type of culture and, population specific. So I'm just going to show you that there were 22 outpatients from 42 facilities that were sending culture to NPHL or Nebraska Medicine too. And these were our Candida isolates, and 44 locations we could not list it because that information was missing. But there were most of the inpatients were coming in from Nebraska Medicine. Candida reports, there were 657 cultures from 385 patients were reported to NPHL in the year 2022. And if you can see the specimens, you'll see that the most common is I think Candida albicans, and then the green ones are C. parapsilosis, the pink ones or the peach colors is albicans, and you can see that it pretty much stayed the same across all the specimen types except for genitals and urine, and also like deep tissue. So I'll kind of show you a little bit more here too. And these are the patient locations, ER, inpatient, outpatient. You can see on this table, that the highest number is again C. albicans, and then C. glabrata and parapsilosis, and then there's some other ones. The patients were median age were 55 years old, and the 61 to 75 years was the highest frequency. So the predilection for growing in blood and tissue specimens, that's a trend. It sometimes Sometimes patients have multiple specimens, so our count may be a little bit off, but not as much. Respiratory specimens may be underrepresented. We can see that C. albicans is the most common, C. parapsilosis is most common in outpatients, and C. Candida glabrata is most common in inpatients. So the recommendations for laboratories that laboratories reliant on non-molecular techniques should ensure they are confirming common misidentifications with molecular methods. Validation should be performed on multi-off systems, and the laboratory technologists need to have accessible guidance. So these three were the recommendations that was kind of coming up with all the data that we had analyzed. And for the health department, there's a lack of colonization screening from high-risk patients. So we need to kind of work on that to see how we can improve that. We can enhance our existing training for healthcare personnel on infection prevention and control, and then collaborate with laboratories in supporting antifungal susceptibility testing. My apologies. So we're that one it's not happening right now. So that's something that we're gonna probably look at that as well. Some of the limitations, no level of detail did not show up in REDCap that much. Some of the time the branching logic didn't work, but it was a very quick survey just to get an idea. And then we also can look at the candidate reports that are coming to NPHL from this big facility. And when I say big facility, you all know what facility that is. So I really, don't have to de-identify here in Nebraska. But so some of the, we need to have the patients' addresses there in order to know if the patients we are covering all over Nebraska, like patients coming from, Scottsbluff, patients coming from the Cherry County. So that's something that we can take a look at it. And then again, organisms added by culture site may be overrepresented due to multiple specimens per patients. So the contributors are, I contributed to that. Dr. Salman Ashraf was, we consulted with him. He's our HEI medical director. And then from University of Nebraska, it was Lisa Young, Dr. David Brett Major, Dr. Sharon Metcalf, and from Nebraska Public Health Laboratory, Dr. Pete Ivan and Benjamin Ayers. So any questions here so far? If I can see the question. Okay, so if not, I think Ben is going to be sharing these slides later. If you have any question, please feel free to reach out to us, or if you have any other ideas or suggestions. Thank you.
Thank you, Ishrat. Yeah, I will make these slides available on the NPHL website, most likely. So thank you. Moving on, NPHL client services. Do we have any new issues this month from last?
We met, this is Brian Lenz, NPHL Client Services. We met in our Monday internal meeting in client services, and nobody brought any issues up.
Okay, great. No issues. We will move into our roll call for outbreak updates. Ishrat, you're back up to the plate. We'll start with the HAI-AR.
Thank you. So HAI-AR outbreak, we are seeing an outbreak of increased Candida parapsilosis, and that's what we're working on right now. There are several patients, and so in 2023, there was a rise in that specific facility, and the patients who were seeking care in that facility and their affiliated other branches. And we are looking at all the procedures that had been done, the surgeries and everything. And the epilinks are kind of all over. So far, we have 16 patients for 2023. And we are doing genome sequencing, and of the specimens that were available to us, NPHL had done it. And then there was a confirmed cluster of those that we were able to retrieve. And so we are kind of narrowing it down, excluding some of our other hypotheses. And more and more we are leaning toward contamination, although we don't know where it is happening. So yeah, we're a month into it, but we'll keep you posted. We're all working, diligently on this. Thank you.
Thanks, Ishrat. COVID-19, any updates?
Yeah, I can give a brief update on that. So our cases are increasing. It's averaging about 90 cases per day now. And similarly, hospitalizations number are also increasing. And currently there are 43 active hospitalizations for COVID, and especially those are among older age groups like 50 years and above. So that's just a brief update on COVID-19.
Thank you. RSV and flu.
Yeah, hi, this is Derek here. Good afternoon, all. So we're creeping closer and closer to the start of influenza and RSV season. Officially, our 2023-24 influenza season or respiratory season will start on week 40, which is the first week of October. Just a few FYIs. Here this week, we are working on scheduling our annual season kickoff call. So be on the lookout for that. We tentatively have it planning on having that on, September 26th, which is a Tuesday. So just be on the lookout for that email this week. Also, we'll be working with the lab on getting collection kits out to our Sentinel sites here coming soon. So just be ready for that. Regarding activity here in Nebraska, I'll start with flu first. We haven't seen any activity for influenza, and to my knowledge, no other states in the country have yet at this point. But with RSV, I don't know if some of you may have heard last week CDC sent a hunt out to report an increase in RSV activity in some states in the Southeast. Historically, states in the South, after states in the Southeast report this increase of RSV and flu activity when that comes around, it's usually a couple weeks later that we'll start to see that activity increase here in Nebraska. So just be aware that we might be seeing some RSV activity increase here towards the end of the month or the start of October. And with that, I think that is all I have, but feel free to reach out with any questions you may have as we're getting closer to respiratory season, and I can throw my email in the chat too, so you all have that.
Hey, Derek, this is Anna Carpenter with NPHL Client Services. Can you make sure that I'm in those email communications regarding the influenza kit sending out to the Sentinel sites? Perfect. Thanks.
Yes, absolutely. Yeah, thank you.
Hey, Derek, it looks like there's a question in the chat from Bill Bolte.
Yes, okay. So looks like it's asking about geriatric RSV vaccines and the clinical trials for pediatric RSV vaccines. Are there concerns, risk about false positives on molecular testing methods, such as what was discussed about measles earlier? So I haven't heard any concerns or risks about false positives with these RSV vaccines. It is going to be interesting, and I think we'll all kind of learn on the fly, not only with that, but a lot of data with this new vaccines being out for RSV. So could very well have more information that as we kind of learn firsthand in the coming weeks and months. So hope that helps.
Okay, thank you. Enteric outbreaks. I have noted that Claire is going to be giving this report now.
Yep, I'm here. So last month, I believe we reported that we had an outbreak related to a tribal event. We had 2 confirmed positives of enteroaggregative E. coli. So that outbreak has actually wrapped up and will be finalized here soon. NPHL did that testing for us, and then we are actually able to send that up to Minnesota's state public health lab, as they do quite a bit of research with these diarrheagenic E. coli's. So they're doing some extra isolation and hopefully some whole genome sequencing for us, so we can get a little bit more specific information on that. And then I think Brianna is going to update us on the crypto outbreak that we're seeing.
Yeah. Hi, Claire. Thanks. Or hi, everyone. Thanks, Claire. Yeah, so I don't think this was mentioned on the last call because we were still looking into it and it was a lot of unknown, but there's a lot of known now. We're investigating a cryptosporidium outbreak in northeastern Nebraska, and we interviewed all 4 cases, and they had direct exposure to a pool, except one did not have exposure to the pool, but the kids did. So possibly a secondary transmission case there. But the clinical lab, they forwarded all 4 specimens to the public health lab, where they did some genotyping for our CryptoNet project. And all of those 4 matched genetically. So that was reassuring that, yes, there's an outbreak going on. And we went up there with actually Department of Environmental and Energy with the pool operator and did an inspection. And we actually were able to collect some swabs and some leftover water that was still there. The pool was already drained a while ago, so but we were still able to collect some water samples and do some swabbing. And we got that sent down to the CDC, and one of our swabs came back positive for crypto. However, we're not able to do any further testing on that because there just wasn't enough genetic material or DNA to do any further testing. So that was pretty cool just to see, there was crypto still found even weeks later. And our next steps is to push out a red cap survey to collect more data from the community and who have possibly went to the pool and if they were exposed and had symptoms. So yeah, that's our next step. We're just waiting on our contact list to do that. So that's it at this time for that.
Okay, thank you. Moving on to arbovirus.
Yes, good afternoon, everybody. So West Nile virus, I guess, is the name of the game right now. We've had a pretty historic season for West Nile virus. First we kind of started out with a significant number of positive mosquito samples. We went over 200 positive samples, which we haven't done since 2014. And what's kind of unique there is that we have half the number of trap sites that we did in 2014. So to go over 200 with half the number of sites is pretty significant, I think. So if you kind of standardize it, number of positives per trap site, we're more than double in terms of that statistic compared to 2014. So most of the positive mosquito samples were coming from the Panhandle region, and we're starting to see the human cases kind of track that. Right now we're at 68 cases. However, there's still 23 that are under investigation. Of the 68 cases, 43 are neuroinvasive. That's about 63%. We do have 2 deaths, unfortunately, and a third death that is going to be probably a confirmed West Nile death. It's currently under investigation right now. Of those 68 cases, again, the majority are from the Panhandle region, which kind of tracks with what we've seen with our mosquito samples. So 26 of the 68 are from the Panhandle, and just kind of going forward here, we're still seeing positive lab reports come in. I can foresee where we might go over 100 cases. We probably are not going to see what we saw in 2018 when we had over 250 cases, just because the majority of the circulation in mosquitoes was occurring, in more rural areas, not necessarily in our urban centers like Omaha, like it was in 2018. So I don't foresee it going that high, but we're still seeing a pretty significant number of cases, especially for these rural areas in Panhandle. This is the highest number of cases they've seen in quite some time. So we'll still see these cases come in. We'll probably see, unfortunately, several other deaths just because we kind of trend around that 10% of our neuroinvasive cases tend to be fatalities. And so we're kind of sitting around that right now. And can foresee where, we'll have more neuroinvasive cases that are getting reported, and we'll probably have, several more deaths, unfortunately. So, with weather coming in, we're kind of coming into the downward trend of the season. The good news is, based on our mosquito surveillance, is that the number of positives and the number of the mosquito population out there being collected in their traps is going down. So hopefully that signifies that we will see, a downward trend in transmission from the mosquitoes to people. But, until we get that really first hard freeze, there's still going to be some risk as we go forward here into fall. So that's the big arboviral update.
Say, Jeff, this is Pete Iwan. Question for you. I became aware of a positive case of death from another facility laboratory, and wondering, when we send our samples from the public health lab to ARUP, we get our positive samples sent back to us for additional testing. What about samples sent to reference labs from other facilities? Are you able to get, or are they coming back to us? I don't believe they are. Are you following up on those to see if they get sent back to us?
No, they're not getting sent back to you because we're not paying for them. So we're not actively going out trying to get them sent back, since they weren't sent through our process of having it sent out, because we did send out. So no, we're not currently following up on those unless we see that maybe there's a death involved, and we can try to see if there's a specimen left, and then we'll try to reach out and get those sent back.
Okay, because there was a recent death that was
you
followed up on that?
Yep, we followed up on it.
Okay,
so I haven't seen if they've, you had reached out to them. I saw that, and I haven't heard anything back whether they're sending that, get that back to you. If not, I guess we can try to ping them again and just see if they're willing to send that back. But I'm okay with just reaching directly out to ARUP if they're okay, and just saying, hey, send it back to you all so we can send it to CDC.
Yeah, well, I'll leave that in your court, Jeff. Of course, we got a process to get the ones that we send off back to us, but not those other ones.
Yeah, it's a whole other process, because we have to get forms filled out by the providers, and the providers have to fill out those forms, and those have to get to the lab, and the lab has to send it. So there's a whole bunch of extra stuff that just gets in the way, and a lot of providers just don't want to fill out that form because they're like, well, we already got the results, so what's the point of it? So
right. I get it. I was just wondering.
Yeah.
And we have seen quite a few come back from ARUP to us, so we're getting a pretty good number of samples that we can send off for further testing to the CDC.
No, that's good. It's good, but yet not good. So yeah, it just means there's a lot of West Nile out there. So
that's right. Yeah, you got it. I think all the ones that have come back with confirmation testing have come back as West Nile. So
yeah, that's what I've seen. So
yeah. All right, thanks.
Mm-hmm.
Thanks, Jeff. TB testing updates.
This is Kristen. I don't have any updates this month.
Okay, thank you. An STD program. Staying on the call. I've got. Doesn't look like Dana's with us today. So we'll move on to lead testing.
We don't have any updates today.
No updates today. All right, great. As far as suspected agents tested at NPHL, Emily is not on the call today. She usually gives us that update. I don't know if Pete, if you have anything to update us.
Yeah, I'm not aware of much. I think we've had one or two Francisella tularensis confirmed over the last month, but that's about it.
Okay.
We've not been getting a lot of rule out cases sent to us recently.
Okay. Under this updates other than leads, Emily did want me to mention to laboratories that NPHL does offer stat lead confirmatory testing with results released the same day if we receive the specimen by 9 a.m. So she wanted me to make mention of that for laboratories sending lead testing over to NPHL. That's my updates. That's my update for the leads. Laboratory training, if you receive the LPX survey, that is probably in your hands now. The gram stain challenge went out. The results came back. We're putting those together. for a final note on the results and how laboratories performed. And then our biothreat rule out and refer wet workshop. Actually, the first one, North Platte, is on Thursday. We're looking forward to getting out there. And then the following week, Thursday in Omaha. Looking forward to everyone visiting us at NPHL. So that'll be fun. We'll open it up. Any comments or questions, open mic for a little while. And again, please, if you haven't yet, put your name and your facility in the chat.